Good morning, everybody. Good morning. Louder. Good morning, everybody. Good morning. That's better. Thank you for being so energetic. I hope you had your good coffee this morning. So, before we even get into what's going on with today's program, and I'm going to be very brief about this, we do want to thank, though, our sponsors of this program. And we have, as you can see on the big screens, we have EMD Serono, we have Mallinckrodt, Genentech, and Celgene. And so I hope that you all appreciate, like me, for what they were able to do for us. All right? Again, and I say this from program to program to program, the pharmaceutical industry needs organizations such as MS Fusing News to provide these educational programs just so that you learn more about all the different aspects about multiple sclerosis. So, again, I am very glad that they're here doing this. And I did already mention the live stream, and I'm glad about that. And I do want to thank our audience out there. So, whoever you are, thank you for being here. Awesome. A lot of people are here today because they wanted to hear this panel. You want to hear everything going on? That's great. So I want to just give you a brief bio of who we have here. Mitzi Williams came all the way down from Atlanta, Georgia. All right. This is Dr. Williams. She's a neurologist. She's an MS fellowship. Her research interests include MS relapse and the course of MS in minority ethnic populations. In addition, she's authored numerous peer-reviewed articles in journals such as Neurology, Clinical Practice, Stroke, and Annals of Pharmacotherapy.
You got it.
Finally.
Good job.
All right. Additionally, Dr. Williams has spoken both nationally and abroad in conjunction with the Accreditation Council of Medical Education, ACCME. She's currently a trustee for the Georgia chapter of the National MS Society. So let's welcome Dr. Williams first. And then we're going to announce Dr. Daniel Kantor. He is an MD and FAAN fellowship, yes, and the neurology residency. He's in the neurology residence program director of Florida Atlantic University, Charles Schmidt College of Medicine in Boca Raton. Yes, okay. And he's the founding president of the Medical Partnership for MS Pain and chair of the subcommittee on concussion for the Sports Medicine Advisory Committee of the Florida High School Athletics Association. He's the past board member and chair education of the Southern Headache Society and past director of the University of Florida Comprehensive MS Center. So there's a lot to know about Dr. Kantor, so let's give him a round of applause. Then we have Tricia Pagnotta. Tricia Pagnotta came all the way down from Orlando. All right. She is a master's prepared ARNP, which is an associated registered nurse practitioner, and she's been a nurse since 1981. She's originally from Baltimore, Maryland, and a graduate of University of Maryland. Tricia has been an active MSCN member, which is the International Organization of MSRNs, since 2006, and she is currently their president. She's very active in education of peers and patients. She organizes and participates in her MS Center's monthly support group meetings. She's an active researcher and participates in her center's research of emerging therapies and published as a primary investigator in MS trials. So let's give her a round of applause. And then, this guy standing here talking to you right now is relinquishing for the first time in 9 years that we have been doing this of moderating the Q&A panel with neurologists, because I've asked Dr. Steingo to do this for me this year. And so I want to let you know something a little bit about Dr. Steingo, because the people that are watching this on live stream don't know, and some of you, maybe in the audience, you may not know him as well. But he's a neurologist in Sunrise, Florida. He received his medical degree from the University of Witwatersrand and has been in practice for more than 20 years. Dr. Steingo has several types of health insurance listed, and what he accepts at his office, and he would like you all to call him and to find out what, if you can get in there. Dr. Steingo is a neurologist with over 30 years of experience in multiple sclerosis. He's the MS director. He's the MSMD director of the Sunrise Medical Group in Sunrise. He's one of the lead investigators in numerous MS clinical trials here in South Florida. These trials have addressed MS drug therapies currently on the market and many innovative ones that are in the pipeline. And so I want to welcome Dr. Steingo. Good job. Take it away. You got 40 minutes.
Good morning and welcome, everyone. And our fearless leader, Stuart,
Thank you for introducing me. I have no idea why the insurance aspect came into this. None. But don't forget, Stuart has MS too. All right? He also has MS, so every now and then he says things that we must forgive. And that's one of them. I have no idea what that has to do with my abilities, is what insurance I take, because that changes every 10 minutes. So in the past, the format of most of this program has been in the 60-minute style of format. 60 minutes. You watch 60 minutes sometimes, where there may be 3 topics that we talk about, and then after that a Q&A. But we're not forgetting the Q&A. We will do the Q&A at the end of the first 40 or 45 minutes. But the first part of this, instead of a Q&A, instead of 20 minutes each, we're going to do this like CNN headline news. And I don't mean that it's fake news. I mean, it's all very real. And what we're going to do is pick topics, and each one of our speakers, and we welcome them and thank them all for being here. Each one of them will spend a few minutes talking about topics and talking about many different topics. And then at the end of that, you'll have plenty of time for a Q&A. So I'm going to start off and go to the first question to Dan, to spend approximately 4 to 5 minutes on this question, which is to update us all a little bit about what we know about causes of MS today and some of the immunological aspects of MS. Thank you.
Thank you. We think of multiple sclerosis as being an autoimmune diagnosis. You're going to notice I'm going to use words like think a lot. And the reason is that I think it's arrogant for us ever to believe in medicine that we understand things fully. Every 20 years, half of what we know right now in medicine is found out to be false. It's found out not just to be false, but to be 180 degrees false. The problem is that we don't know right now what that's going to be in 20 years. So what's our best understanding? How do we think MS works? Well, we think what happens is that the body, instead of just fighting outside invaders like viruses, bacteria, fungi, and even attacking cancers, the body gets misdirected and starts to attack yourself. When it happens in the joints, we call that rheumatoid arthritis. When it happens in the pancreas, we call that juvenile diabetes mellitus or diabetes mellitus type 1. When it happens in the skin, one of the things we call it is psoriasis. When it happens on the nerves and the covering of the nerves, by the way, what's the covering of the nerves called? I'm sorry, I always feel the need to ask that. You know, I can't go to a group of people with migraine and ask them neuroanatomy questions, but I can always talk to a group of people with multiple sclerosis and ask them these sorts of questions. So when the body attacks the nerves and the covering of the nerves called myelin, we call that multiple sclerosis. So normally the body's defense forces are there to defend yourself. But when it gets confused, that's when problems can happen. We think of MS as being not just because of your genes that you have, of who you are and who your family members are, but also some sort of environmental exposure and probably an early environmental exposure. When Michael J. Fox, who I would say is America's sweetheart, was describing Parkinson's disease, and Parkinson's is very different from multiple sclerosis, but when he was describing Parkinson's disease, he said that in Parkinson's, what happens is your genetics loads the gun, and then the environment pulls the trigger. He could have been talking about multiple sclerosis. We used to say we didn't know that much about the genes and the environment in MS, and now we know a lot more. We have over 200 genes that we think are associated with multiple sclerosis. That doesn't mean that there's one gene that's the MS gene, but that there are things that make you more at risk for having multiple sclerosis. And in fact, some people, you're going to see multiple family members with MS. Most people with MS, though, you're not going to find any other family members with multiple sclerosis. But you may have a family member with lupus, another family member with rheumatoid arthritis, somebody else with thyroid disease, somebody else with other types of autoimmune diagnoses. But yes, there are families where there are multiple people with multiple sclerosis. In terms of the environment, we used to think we didn't know that much. Now we're learning a lot more. The #1 environmental factor that's important in multiple sclerosis is smoking cigarettes. Smoking cigarettes leads to a younger age of diagnosis, it leads to more relapses, and it can lead to more progression of disability, and if somebody's still taking self-injectables, it can actually lead to more skin site reactions. But we're learning a lot more things. In Southern California, we learned that the closer you live to the highway, the higher your risk of multiple sclerosis. So we know that environmental pollution is important. I think a lot of people have seen data on vitamin D and how having lower vitamin D can put you at greater risk for multiple sclerosis. So we're learning more about that mixture of the environment and the genetics. In terms of what happens in the body fighting itself, we used to talk a lot about T cells, and that's just a type of immune cells. We just give it a name and we call it T cells. Now there's been much more focus not just on T cells, but also on the other cells, such as B cells. And so we're learning more about what happens in terms of the immunology of multiple sclerosis, and we're learning more every day.
Okay, thank you very much. We all know that the commonest way that MS presents and starts is with relapses. The commonest form of MS is called relapsing MS, and a less common form is progressive MS. What we selected as our next topic for Mitzi to go ahead and talk to us about is about MS relapses, understanding what a relapse is, and talking also briefly about management of MS relapses. Please, go ahead.
Absolutely. And I'm excited. I think I traveled the farthest to be here on the panel, so thank you for having me. So MS relapses are really a hot topic, and I find it really interesting because in seeing people living with MS, oftentimes whether I see a person who is a brand new diagnosis, meaning they got diagnosed last week or last month, or if someone has had MS for maybe 10 or 20 years, I always get the question, how do I know I'm having a relapse? So I think it's very important to recognize and know the symptoms of relapse. And I think the first part of that is to recognize that they're different in each person. So typically when we define a relapse, we say that it is a new neurologic symptom, right? Or significant worsening of your old symptoms that lasts at least 24 hours and is not accompanied by fever or infection. Why is that important? Because if you have a fever or if you have infection, or if, I don't know how hot the temperatures are here, but certainly in Georgia, the summers get super hot, right? So if people have been out in that Georgia hot sun, sometimes those MS symptoms can temporarily get worse. And that is what we call a pseudo-relapse, but not what we call a true relapse. So we believe that relapses are due to a new attack or a new area of inflammation in the brain or spinal cord that is causing a person to have that symptom. The reason we also suggest that relapse symptoms should last more than 24 hours is because sometimes you just have a bad day, right? If you have difficulty with your balance, or if you have weakness or numbness, I see lots of heads nodding. If you ever woken up and your balance is just off, and you just wake up and you're off, and you go to bed that night, you wake up the next day and you're back to normal. Has that ever happened to anybody? Okay, so that's not a relapse, right? That's why we say give it 24 hours, right? Because sometimes you'll just have a crummy day, right? But typically a relapse lasts several days to several weeks, and there are certain things that we can do to try to treat those relapses. So the symptoms can be numbness or tingling, the symptoms can be loss of vision, the symptoms can be increase in spasticity, for some folks fatigue. So again, it can be the old symptoms returning or a brand new neurologic symptom. If you ever have a new symptom that lasts at least 24 hours, you need to be getting in contact with your physician, okay? So commonly folks will ask, when should I call my doctor? If you're having a new symptom, call your doctor. If your old symptoms are worse for more than a couple of days, call your doctor and check in. So why do we say contact your doctor? Because what can we do about it, right? So there are treatments for MS relapses. Has anybody ever had steroids? Raise your hand real high. Yes, so steroids are the most common treatment that we give for an acute relapse. Oftentimes they're given in the IV, right? So we give IV high-dose corticosteroids, it's called Solumedrol. However, in more recent years, there has been some shift toward giving steroids orally. So some of our colleagues, especially in Canada, have been giving high doses of oral steroids for some time. And so some of us are adopting that as well for a variety of reasons. Sometimes you might live very far away from your doctor. Sometimes you may have difficulty coming in for an infusion. So again, steroids are kind of the main treatment that we give. The goal of the steroids is to speed up your body's ability to recover, okay? So the steroids do not necessarily treat the underlying autoimmune process. There are some, discussions about whether we think that steroids have a long-term effect. They may or may not, but for the most part, they are used to try to speed up your body's ability to recover so that we can get you back to doing the things that you normally do as quickly as possible, right? So if we can get you back into action in a week versus 6 weeks, then we'd rather do that. that, right? So steroids are certainly the most common treatment. Another treatment that can be used is there is a treatment called Acthar or ACTH. It's kind of an old school treatment that was used way back in the 60s and then kind of fell out of favor, and then it's kind of reemerged. It is an injection that's done at home for several days and usually is given for people who cannot tolerate steroids. So I have some folks that get very, very grumpy when they get steroids, or I have some folks that actually have other symptoms like a lot of bloating or their blood pressure goes up, or for some people who have diabetes, it may make their glucose or sugar levels very high. So for folks who can't tolerate steroids, or for folks that steroids have not worked for, then ACTH is an option. And then there are a couple of other options that we don't use as commonly, but depending on your physician, sometimes if you have a relapse with symptoms in the spinal cord, they may use other treatments such as IVIG, which is an IV treatment, or plasma exchange, which is a process that's done in the hospital. So there are options available. I think the important thing is to know if you're not feeling normal, if you're feeling like those symptoms are worse for a couple of days, or if you're having a new symptom, ring that alarm, let somebody know so that you can check in with your doctor and see what options are the best ones for you.
Thank you, Mitzi. Thank you very much. Next topic, very important topic. Many of you will know that this is a very important year for MS. This is an anniversary year. The first drug approved by the FDA for MS was approved in 1993, so that was beta-seron improved in 1993, that's 25 years ago. So a very important year this year, anniversary. So our next topic that Tricia is going to try and cover in about 5 minutes is to tell you about the current disease-modifying or disease-managing drugs that we currently have available. Tricia.
Okay, great. Thank you. So that's the hallmark, 25 years. The good news is we have several disease-modifying therapies. And so amen to that. So everyone who has a treatable form of multiple sclerosis, I hope that you're considering disease-modifying therapy. So initially we had therapies that you self-injected. So there's a variety of those, and we yet to have a generic one of those, but we do have the interferons, and interferons are self-injecting. You give them either every other day, 3 days a week, once a week, or even every 2 weeks. So there are different ways that again is given and how that releases in the body, but they're all designed to help reduce the inflammatory component of your multiple sclerosis. So that's what those drugs are designed to do. Side effects from those drugs, you're injecting it, so you could get an injection site reaction. That would not be uncommon. That's why it's very important to rotate your injection sites. You can also, with these medications, sometimes have what we call flu-like reactions that occur early on. Most of the time, for most individuals, these reactions improve over time, but you can pre-medicate for those. So depending upon how you respond, you can pre-medicate with anti-inflammatory type of medications, and then redose yourself depending, again, on what time you take your dose and whatnot. So it's extremely important that you consider that. And those drugs have been approved for a while. We have the most data on them, but we know that those drugs improve relapses, disability, MMRI progression. Now, also in the self-injecting medications, we have Copaxone. And Copaxone, now we have 2 generics, Glitopia and glitiramer acetate of Copaxone. And so Copaxone itself is available in a everyday injection, or you can give it to yourself 3 times a week. And this is a medication that is, again, helping your body be less inflammatory, help those T cells be less inflammatory and more anti-inflammatory. And I describe to persons, this is like giving yourself sort of like an allergy shot. You're giving yourself a mixture of polymers to help your body not be as inflammatory. And With this drug, you can have injection site reactions, and over time, with all of the medications, you could get what we call lipoatrophy, which is a denting of your skin. It's more commonly seen, though, with Copaxone than some of the other medications. The other thing with Copaxone, glatiramer, that you can get is a post-injection reaction. Some persons get this once and never get it again. I've had some persons say that they've never had it, and I've had some persons say that they've had it several times. And a post-injection reaction is you inject yourself, and within minutes after, you start to feel maybe short of breath, feel like your throat is closing, maybe your heart's beating a little bit faster. And persons describe it as though they feel like they're having a heart attack. And several persons have called 911 because they think they're having a heart attack. The symptoms will resolve, and most of the time resolve before EMS gets there if you're the one that called EMS. So usually within 10 minutes the symptoms resolve, but it can be very scary if you didn't anticipate that potentially that could happen to you. And there's not a pre-medication that we give to help that not happen, because it happens so infrequently, and if you took anything, it wouldn't be effective anyway. But the other thing is Copaxone is the only drug that we have that doesn't require any monitoring. Because this drug does not interfere with your liver or anything, and you don't require any monitoring. With the interferons, there is some monitoring of your liver enzymes that need to occur, and your blood counts. And so with those drugs, you periodically need to have some blood work done. So with Copaxone, you don't. So that covers the basis of self-injecting type of medications. And then we move up to where we have oral medications, and we now have 3 oral medications. And the biggest thing is looking at the mechanism of action of drugs. So if you are doing well on one drug and you are tolerating whatever the monitoring and injection the administration is, you obviously would not consider changing unless your disease is still active. But if your disease is active, then when you change a therapy, you want to think about the mechanism of action. So I've had persons, and before we had all these drugs, we used to switch from one interferon to another. Well, now we don't have to do that. We would move to another. So you'd look for a different mechanism of action. So the oral drugs all have different mechanisms of action. Tecfidera works on your NRF2, your antioxidative pathway. Gilenya sequesters lymphocytes and reduces the amount of then you have available to get into the central nervous system. Aubagio reduces the overactivity. So that's the oral drugs. All of the oral drugs have monitoring that's required with them. We then have monoclonal antibodies. Monoclonal antibodies are IV infusions that are designed to go at a particular part of your immune system and make that less active. So with Tysabri, the mechanism of action of that is to shore up the blood-brain barrier. So it goes in and affects the VCAM molecules and makes your blood-brain barrier thicker so that the cells can't get into your brain. The mechanism of action of Lemtrada is to reduce T and B cells. It goes in, ablates them, they come back, and so that's the mechanism of that. Ocrevus goes in and depletes B cells, and so then you're continually depleting B cells. So the monoclonal antibodies all have a different mechanism of action and work to reduce your immune system or reset your immune system. All of these drugs also require monitoring. So again, where are you, how are you doing, and then you have a discussion with your healthcare provider about a drug that's right for you.
Thank you, Tricia. Going forward, we have approximately 4 minutes to summarize, just in a nutshell. This is headline news. So the next question is a dilemma we face in the clinic all the time. Is the medication working for me? When do we switch? How do we make these considerations? Mitzi, if you could please go ahead and take that topic.
Absolutely. Headline news. Let's go. All right. So it's a very common question. How do I know a medication is working? I think that this is very important and unique in terms of MS and autoimmune disease, because the way that we treat and the goal of our treatments are very different from what we typically think of when we think about taking medicines, right? So often we think, if I have a headache, I take this medication and I feel better. So generally when we think of medicine, the goal is to feel better. However, with multiple sclerosis and our disease-modifying therapies in particular, that's not necessarily our goal, right? Our goal right now is stability. We're working towards medications where hopefully we can see improvement, but our goal is stability, right? So the things that we look at are, we look at you, right? When you see your doctor, are you having those relapses that we discussed? Are you having progression or worsening of your symptoms since the last time you were seen? And the other thing that we look at is the MRIs. So basically we look at you and we look at your MRIs to determine how a person is doing and if the treatment is effective. So when people come to visit me and we start a new medication, I go through my whole spiel. I say, you know, the goal is stability. The goal is not to feel better. And inevitably, many people will come back for that first follow-up visit and say, well, Dr. Williams, I don't feel any better. And what I say is, great. Right? So we say that's great, because what we don't want is for you to feel worse. Okay? Now, if you feel better, your body can heal itself to a certain extent, right? So after relapses, oftentimes people will recover or improve on their own. But when we're talking about the goals of our medication, we want to come back and we want you to be stable. So I tell my patients that I basically want to have social visits where I show them pictures of my super cute kids, right? And they tell me what vacation they went on, and we don't really talk about your MS. Okay? So stability is the goal, and that's how we know it's working. So following up with your doctor, getting those MRIs checked regularly, keeping track of your symptoms, keeping track of symptoms of relapse are very important to determine where we are and if we should switch therapy.
Thank you very much. Okay. Now we're going to have a little summary. Trish, if you could summarize for us new and emerging MS treatments. What new drugs are on the horizon and new methods of treatment. If you could go ahead, please, and do that.
Wow. So there are a couple, there's several oral therapies that are on the horizon, and so some of them have a similar mechanism of action to Gilenya, and we are hoping that at least one of those will get the approval for secondary progressive multiple sclerosis. So on the horizon is potentially a treatment for secondary progressive. So we're hoping that that comes out next year. We also do have another therapy, another oral therapy that's coming out, hopefully. The FDA will approve. So in the cladribine. So hopefully in the next year, we will have 2 or 3 oral therapies that will be coming out. There are still IV therapies that are in trials. I don't think any of those will come out next year. So basically, we're looking at drugs that will keep lymphocytes in your lymph nodes, or the cladribine.
Oh, we made up some time. Thank you. These topics have been selected largely from what people with MS are requesting. So that's why we're trying to cover all these topics. So going forward, your input will be very valuable for what format we should take next year and what topics to discuss. The next topic that they had listed was symptom management. Now, you can't do that in 4 minutes. It's hard to do it in a day. But I'm going to go ahead and ask Dan to cover some aspects of some of the important symptoms, and we'll change. Here, this is the symptoms that they listed. Just pick some of them. So what we're going to do is we're going to give you a double session now, and that's the way we're going to go toward the end of this. So let's say you have 8 minutes to talk to us about some of the important symptoms. If you don't need that, we'll do other things. We have plenty to talk about. So maybe you can spend about 8 minutes and highlight some of the symptoms that they have requested us to talk about, current state, maybe future directions, anything exciting. You have, go ahead for about 8 minutes.
Sure. So when we think about the symptoms of multiple sclerosis, that's probably the most amount of things that we actually talk to our patients with. You know, a lot of focus, and we heard from Tricia, we heard a lot of focus on disease-modifying therapies. We think of those as proactive medications, how to ensure your future. But most of what happens when you go to see your doctor or nurse practitioner or physician assistant has to do with the things that are bothering you. So it has to do with individual symptoms. And everybody with MS has a little bit of a different story. MS affects the central nervous system. And so when you go to the world's most famous doctor, Dr. Google, and you type almost anything, you're going to find multiple sclerosis as one of those. So I like to think about the treatment of MS actually having to do with three things. So on the one side, we have the disease-modifying therapies, and we've heard a great overview of those. On the other side, we have symptomatic management, and in the middle, we have rescue therapy. If you're having too much rescue therapy, that means you're having too many relapses, it might mean your disease-modifying therapy isn't the right one for you. But let's focus on symptomatic management. Notice I said symptomatic management, I didn't say symptomatic medications. Much of what we do does not involve medications. And in fact, you heard earlier a great talk about yoga and MS. A lot of what we do involves breathing exercises, mindful meditation, yoga, tai chi. Yes, we sometimes do use medications, but most of the time those medicines are what we call off-label, meaning we're not using them for the reason that they're indicated by the Food and Drug Administration. So if you've ever been on anything for MS and pain, that's not FDA approved for MS and pain. If you've ever been on anything for MS and thinking, that's not FDA approved for MS and thinking. If you've ever been on anything for MS and fatigue, that's not FDA approved for MS and fatigue. We do have some medications that actually have the word multiple sclerosis in them, and they're used for individual symptoms. So for example, we have a way of helping people with MS walk better. And we have a medication that helps to do that. That medication, called dalfampridine or Ampera, what it does is it helps your nerves conduct electricity better. And normally, what happens in a nerve is that people use this comparison to an electrical wire. And they say, well, the wire, the covering of the wire gets stripped off. Well, it's actually a little bit different in MS. It's in your body, it's not that the electricity goes inside the wire. It actually jumps on the outside of the wire. And we actually call that saltatory conduction. I never understood why it was called saltatory conduction. I thought it had to do with salt, with sodium and potassium. And then I was watching Dora the Explorer with my niece, and she said, Diego, salta, salta. And I realized because salta means jump, that's what's happening, is it's jumping on the outside. And what this medication does is by prolonging those action potentials, it allows the electricity to jump better and to act more similarly to what happens normally. We do sometimes even use for something called spasticity or muscle tightness. A lot of what we do is stretching exercises, physical and occupational therapy, yoga. Sometimes we have oral medications that can help with spasticity reduction. And then we have other ways of doing that. One way is we actually implant something called an intrathecal baclofen pump. And this is a pump that has inside it baclofen. And the idea is instead of some of the side effects that you can have with baclofen when you take it orally, you're getting it and it's going straight into your central nervous system. It's going into the spinal fluid around your brain and spinal cord. We also have other ways of reducing spasticity. One way is to give botulinum toxin. And the idea is by giving this, it's reducing the spasticity or the muscle tightness that you're having as well. Then there are other medications for spasticity that are in development right now. Newer ways of kind of changing the baclofen molecule a little bit to make it easier for you to be on it. People often with multiple sclerosis have visual issues. And the visual issues can come from different types of problems with multiple sclerosis. And I think one of the important things is to not just lump them all together and say, well, I have MS and so I have visual problems. Well, those visual problems could be because of the optic nerve itself, the nerve that leads to the brain and send those signals. It can have to do with problems with keeping your eyes moving together, and that can lead to double vision and even blurry vision. There can be even processing problems that happen. So one of the important things that has to do with vision in MS is to first figure out why it's happening. because why it's happening is going to affect different things. If it has to do with double vision, then there may be corrective things that can be done in terms of glasses, even if you wear glasses or even if you don't, with putting something called a prism in there. And the idea is to bring those eyes and align them better, and so you don't have that double vision or that blurry vision. If it has to do with the optic nerve, then it's something that sometimes will take time to recover, and other times we might use medications in an off-label way to try to improve that as well. A lot of people with MS report fatigue. And the fatigue that happens in MS, for those of you who don't have MS in the audience, who are the care partners, firstly, thank you for being the care partners. But it may be difficult sometimes to understand what MS fatigue feels like, and it's a very deep and troubling sort of symptom that not just affects somebody physically, but affects somebody mentally as well. And so with fatigue, there's different ways that people can treat it. Some of those have to do with medications. We may use stimulants or medications that keep you more alert. We may use medications that actually help fatigue in other kinds of conditions, like people with narcolepsy or people with obstructive sleep apnea, and we may do that. But even in fatigue, I think that the first thing you should do is figure out why you're having that fatigue. The most common reason for fatigue in people with MS is not the MS itself. It's the same as the most common reason for fatigue in the general population. In America, we have what's called poor sleep hygiene. We don't sleep correctly. The bedroom should be used for two things, and one of those is sleeping. And the other one is not watching TV, and it took some people a little while. It's not watching TV and eating in bed. But we don't do those things correctly. And so what you have to do is make sure that you're having proper sleep hygiene. All of us, as we eat more of a Western diet as opposed to Eastern diets, what happens is our necks get bigger and bigger. And so obstructive sleep apnea is also a major problem in this country, and also a major problem with people with multiple sclerosis. And so if people are not sleeping well, then that means they're going to be fatigued throughout the day. And so perhaps having a sleep study or doing that. What I want to conclude with is that there are a lot of ways of dealing with the various symptoms. But one of the first things you should do is make sure you understand why you're having that symptom, whether it's related directly to the MS or whether it's because of the MS, but not from the MS itself. For example, lower back pain. Well, even though you think of this as your spinal cord, in the lower back, there isn't that central nervous system. So when people have lower back pain, it's not from the MS itself. But if you're not walking right, then you're putting stress in your lower back, then you will be having lower back pain. And so figuring out what you need to fix is very important. Unfortunately, when we talked about disease-modifying therapies, there's no supplement or diet that's yet been proven to be effective in disease-modifying. But I would say that there are diets that can be more helpful in terms of symptoms. A lot of these diets are mutually exclusive. The best study that was done was actually using a modified vegan diet. So vegan means no animal products, as Dr. Steingo well knows. And the McDougall vegan diet means no fun. So it's a low-fat version of the vegan diet. And what happens with that is at the end of the year, people didn't do better in terms of their MS relapses, their MS progression, their MRI. But there was a 20-pound weight loss, reduction in cholesterol, reduction in blood pressure, and I think most interestingly, a reduction in MS-related fatigue. So there are definitely things that you can do with your diet and exercise that can help the individual symptoms that you have with multiple sclerosis.
Thank you, Dan. The purpose of this program is for education of people with MS. Sometimes our colleagues also need some education, such as my friend Dan, needing some education about diet and vegan diet. He does need some education. We're working on it. Yeah, there you go. Okay. Oh, okay. So MS is a disease that typically, as we all know, occurs between the age of about 20 to 45. That's the classic, but MS occurs much younger and at much older age groups. And at different age groups, MS has different effects on people's lives, on the family, on finances, on many different things. So the next topic that we wanted to touch on is the effect of MS at different ages on family life, and a special emphasis maybe on MS and women's health. Let's see if you can please go ahead and touch that topic.
Absolutely. So one of the challenging things about MS is that it is an unpredictable disease, but I think another thing that can be very challenging is when people are diagnosed, even in those typical age groups that we think of between 20 and 40, it's often during the time when people are trying to figure out what they want to do with their lives, right? Someone may be in school, maybe in college, maybe starting a career, and so then this MS diagnosis comes, and with it often comes this fear of the unknown. And depending on the type of symptoms that people have, depending on the types of relapses they have, they may encounter certain challenges during the course of disease. So, for instance, I've had some patients who, after finishing a degree or a graduate degree, they may have a relapse and may not be able to work in the field that they had been working all this time to be in, or people who've had lucrative careers for some time and may encounter a relapse or a symptom that may prohibit them from doing that. So there often is a lot of adjustment. So I often counsel patients that MS is not a death sentence, but it can be an adjustment sentence, right? And we have to make those adjustments as we go along during the course of disease. I think in terms of women's health, since the disease does occur primarily in women, 3 times more common in women than men, there are certain special issues that we try to address, including pregnancy and, for instance, menopause, right? I just did a talk with one of my colleagues who's an OBGYN about women's health and MS, and literally everybody wanted to hear about was the hormones. So I just went and sat in the corner and let her talk, because nobody wanted to hear from me. They all want to hear from her. But in terms of pregnancy, there are certainly issues with pregnancy. So we do a lot of discussion about family planning. Most of our medications are not recommended during pregnancy. So often when we talk about family planning, we have to discuss if we're going to come off of medication and how we're going to do that safely, and how we kind of check in during the time where people are trying to conceive, because it often is not an automatic process. Sometimes it takes a while, takes a little practice. And so during that time when people are trying to conceive, we have to do kind of checking MRIs, make sure things are stable while they're off of their medications to try to get pregnant. And then oftentimes there's a lot of discussion after pregnancy about breastfeeding. During the first couple of months following pregnancy, it's a very common time where people have relapses. For many of my female patients, that's when they get diagnosed, is they'll say, I had my first child, and after I had my baby, I had numbness in my leg, or I had difficulty seeing, or I had this other issue. So those things have to be kind of carefully planned with you and your physician to determine the best course of action in terms of therapy, as well as restarting therapy following pregnancy. And then there are also issues surrounding menopause. Often with the change in hormones, women may have increase in their MS symptoms during menopause, especially when people are having those hot flashes or personal summers, as my aunt likes to call them. When they're having those personal summers, it sometimes can temporarily make those symptoms worse, because we discussed how heat makes MS symptoms temporarily worse. So a lot of those things involve collaboration with your neurologist, as well as with your OBGYN or other physicians that are treating MS. I think in other terms, again, there can be a lot of transition, but when you have a good relationship with your neurologist and you're checking in on a regular basis, you guys can kind of encounter ways to deal with those transitions as they come.
Thank you. We have one more topic to cover before we do the question and answer session. We did not hand out index cards, but in front of you, I think everybody has the agenda. So if you prefer to write down a question, if you have a question on your mind and you don't want to do it live, and you prefer to write it down, maybe on the back of the agenda, if you have some paper, you can just write your question down and hand it to us, and we'll cover it in the Q&A session. But the final session that Tricia is going to discuss with us is the question about how you gain access to effective care, how you become a self-advocate for yourself through knowledge, through self-reliance, how you're part of a team to gain the best of care for yourself. So, Tricia, if you can please take that final question.
Well, thank you. So again, active means that you are participating in your care. And so as you see us up here talking, and you go through any of Stuart's videos, you see some of the premier persons who are acknowledged in the MS community. And maybe that person doesn't live in your community, but you can call, they have a social worker with MS Views and News, and find somebody that does do MS in your community. So finding someone is important that does MS. And then recognizing when you go in and see that person that it's a partnership, that you share what you have going on, and you share what your goals are, and then you partner with that individual, and that person hears you, and you move through that process of deciding whether or not you're on the right therapy, or your symptoms being managed, and you give input into that. Now, some persons talk to me about the fact, well, that's all fine and dandy, but my insurance doesn't cover me to go to this person, that person, or the other. So then you might have to be a little more creative. And in situations like that, you're spending more time having to help out potentially the general neurologist that only your insurance will let you go to. So you have to advocate for yourself. Why can't I be on this? Or how about this? I heard about this. I heard about that. And sometimes you may have to seek resources from many different organizations. So there are lots of not-for-profits that help persons who have MS. And so I tell persons, that this disease, it's wonderful that it's not a common disease, because A, it's devastating, nobody wants to have it, but in addition to it not being a common disease, there's lots of help for persons who do have MS. But that help is not going to come knock on your door. That help requires that you acknowledge, I need help, and what can I do? And so then you start knocking on all doors. This is a great time of the year for you to think about that. Think about the troubles that you had in 2018. Think about what you anticipate for 2019. So that starts with, if you have insurance, what type of insurance decisions do you make as far as, well, I need to make sure that my neurology team is on my insurance coverage. I need to think about, if I've got a health savings account, what expenses did I have last year, so I put that money in for this year's health savings account. Persons who have Medicare and all of these Medicare option plans, they all sound great when they're cutting down your cost or co-share for, but if it doesn't cover anything that you need, you didn't save any money. So thinking about that, and so getting help from the organizations that help persons with MS. MS Views and News is one of them, MS Society, MS Foundation. There are many organizations that can help you with that. But if you think about, you've got all of those things covered, and in 2018 I had these challenges. Well, you know what? We're preparing for 2019. Start writing letters. Start writing, well, here's what I needed last year. Get a letter together that says, I have MS, and here are my challenges, and here's what I really need. And send it off to every not-for-profit that you have. If one of the things that I have to say that Orcorda has done very well is they've got this book, this MS book, that has all kinds of resources in there as far as all the not-for-profits. You send your letter out to every single one of them, and it's amazing what I have seen persons get money for. And so think about what your needs are, but the thing is that you need to be active, and you need to engage yourself. And doing that in a proactive way, getting help from your healthcare providers and getting help from the community is extremely important.
Thank you. Thank you very much. So some of you who know me well know that I like quotes. And one of my favorite quotes that applies is this one. It's that things don't always happen for the best, but make the best of the things that happen. And so I thank the panel for, in this short period of time, making the best and telling us and giving us so much amazing information in this short period of time. Thank you very much.
All right,
So who's got a question that's right in front of me?
I just had a question about the CBD oil. Your thoughts on that?
CBD oil? Okay, we'll just start with the panel. If you can answer the first question, please, on CBD oil.
So the question was about CBD oil, so the cannabinoid oil. It's going to depend a lot on also what your doctor's kind of stance is on cannabinoids in general. So in the state of Florida, you know, previously we did not have medical marijuana. Now we do have laws in place that allow some medicinal marijuana. You know, when you look at the use of marijuana and its components for different aspects in medicine in general, a lot of the things that it's touted for have actually been shown not to work that well. So one of the things that's touted for a lot is epilepsy or seizures. And seizures, there's very few seizure syndromes where it actually seems to help. Probably where there's the most data actually has to do with its use for spasticity or muscle tightness in multiple sclerosis. And in multiple sclerosis, what showed to happen was it didn't reduce people's spasticity or muscle tightness objectively when they were examined by a physician or by a nurse practitioner or physician assistant, but it was a subjective feeling, a feeling that people in general felt that they were having a reduction. And so, you know, I think we're still kind of early in that world of where do we see cannabinoids in general, where do we see CBD oil, and I'd be curious to hear what other people on the panel have to think about it as well.
Absolutely. So I think that most of the research, which was primarily done overseas, like in Germany with nabiximol, which is an oil, CBD, a cannabinoid oil, did show that it primarily helped with spasticity. I think there's more work that needs to be done because most of what is being used here in the U.S., many patients are actually using the smoked form of marijuana, so of THC. So there's a lot that we don't know. Hopefully now that there's legalization in certain states, we'll have better information about how the chemicals affect MS. I know that certainly with the primary form that many of my patients have used, there are issues with cognitive dysfunction. So when people smoke, there are issues with possible cognitive dysfunction, which is also a symptom of MS. So I think that there certainly is some evidence to suggest some improvement with spasticity, but I think that there's a lot more research that needs to be done with how people are actually using the chemicals because people are not primarily using the oil.
So I tell persons, again, we don't have a lot of research, so you're an N of 1. If you're going to try cannabis in any form, whether it's smoked, oils, or whatever, you get yourself a journal and you write down what you're doing, what you got, what symptom you were trying to manage, what dose you took, and did that help you? And when you go to the dispensary, make sure that you are telling the person in the dispensary what your limitations as far as your function is. Because I had a person come in my office, and thank goodness she was with her care partner, and she doesn't usually have her care partner with her, but they were out shopping. Anyhow, she had just not too long ago got from the dispensary this little dropper that she was supposed to give herself this oil underneath her tongue with this little dropper. Well, she doesn't give herself injections or many other things very well. She can't even open her pill container very well. And the thought that she could manage this little dropper, well, of course, she came in my office quite impaired because one little drop turned out to be, I think, the whole dropper full. And so, again, it's important that if you think this might be something that could be helpful to you, you go about it the right way and you do your own self-experiment. And if it works for you and you're sure that nothing else is going on, so as Dr. Williams said, we have seen, and the neuropsychologists are telling us about cognitive impairments. So it's very important that you look, well, is it helping the symptom that I want it to help? And am I having any side effects? And those side effects, look for things. Are you gaining weight? Are you having difficulty remembering things? Are you being moody? Are you withdrawing? You know, I've heard of persons that have taken marijuana and they're very active, and I've heard of persons that then become very paranoid. So again, do your own research, keep a journal so that you are able to make sure that what you're doing is really working for you. And if it's working for you and it's not hurting you, and then you don't decide that, oh, it's going to cure my MS because some of my symptoms are better, that's the only thing. Something that makes your symptoms better. We don't have any data that this or any other symptom management drug modifies your disease. So good, treat your symptoms, but still manage your disease.
Thank you. What is the next question?
Hi, could you please tell me what the difference between progressive MS and regular MS is? What is progressive?
Absolutely. So the difference between progressive MS and relapsing MS. So, you know, the way that we used to think of MS as kind of different boxes, right? People fit in different boxes. So traditionally we've said, okay, 85% of people have relapsing MS, right? That's where you have a symptom that comes on, lasts for a period of time, goes away. You have those relapses, those acute symptoms, kind of like a roller coaster. And people generally develop disability over time because you get a little bit left over after each one of those episodes. Progressive MS actually comes in two forms. So there is primary progressive MS, and those are the people who start with symptoms and they just generally just tend to get a little bit worse over time. So they don't really have very many of those episodes, those acute episodes, kind of like a roller coaster. But there is also secondary progressive MS. So some of those people who start out with the symptoms and the relapses may eventually just notice a little bit of worsening over time and very few of those relapses. I think that the MS community in general has kind of modified some of our thinking to recognize that there is often relapses and progression going on at the same time. So people don't necessarily fit in those neat little buckets like we used to think about it. So often both things are going on at the same time, but the way that we generally categorize somebody's MS, so when you go into the doctor and say, what type of MS do I have? The way we generally put it in a category is what's the most of what's going on, right? So is the majority of what's going on with you that things are just getting a little bit worse over time, or is the majority of what's going on you're having those relapses maybe every 6 months or maybe once a year? So that's typically the difference in progressive versus relapsing MS.
Okay, thank you, Mitzi. Next question.
Actually, Dr. Steingo, my question's for you. I seen your paper out there on the Tisabri and going to the 6 weeks. I was in the thought that that was already a possibility. It is not to be effective as 4 weeks.
So I'm going to defer to the panel first, which is Tricia is the next panelist. You can do this in a couple of minutes.
Okay, a couple of minutes. So there are persons who are JC positive, meaning that they have been exposed to the virus and potentially they could get PML. So persons who are positive and are having great benefit from Tisabri and their infusion number is greater than 24, they're starting to mount the higher potential of getting PML. Many providers are changing the dosing from 4 weeks, 28 days, to gradually possibly building them up to every 8 weeks. For some persons, they can only go every 5, 6, 7, whatever. The goal is to get you to have less Tisabri infusions, but not have any change in your stability of disease. So it's not that, okay, we're all of a sudden going to, okay, now you're going to go to every 6 weeks. Typically, it's a gradual change to see at what is the dose for you that will keep you stable. And that then over time reduces how many Tisabri infusions you get. And what we know about the possibility of PML is JC status, number of infusions, and whether you've ever had an immunosuppressant therapy. So it's just to be able to reduce the number of infusions you get.
Thank you.
Thank you. Now we have a question asking, are there any preventatives for MS?
Okay.
Well, I would say the preventative is what we know that children or adolescents that are higher risk for MS are obese persons who also have high salt diets and who smoke and who have low vitamin D levels. So stay healthy. Don't get obese as a child. Have a low salt diet. Keep a healthy vitamin D. And then that's the best you can do.
Over here. Who had it? You or you?
We both do. I was wondering, on the itinerary, you talk about Botox and the bladder. Is that on the itinerary? You talk about Botox and the bladder. Is that oftenly used?
When we talk about different symptoms of MS, one of the symptoms can be an effect on your bladder. And oftentimes we call that there's different types of bladder dysfunction that can happen in multiple sclerosis, but one of them that we talk about is called neurogenic bladder. And basically the nerves aren't communicating well enough with your bladder. Normally a person drinks fluid and then they feel like their bladder is full and then they go to the restroom and they can void. Somebody with multiple sclerosis may have a problem where they're getting too much the bladder is getting too full and it's becoming too distended without being able to go and to void. And other people may have a problem where they're actually losing the urine, and so they're having what we call bladder incontinence as well. There are sometimes oral medications that we can use to help with bladder dysfunction in MS. Sometimes it's going to be your neurologist or the neurology physician assistant or nurse practitioner who's going to be doing that. Sometimes it's going to be that the neurologist sends you to another specialist called a urologist. Sometimes people will go and see a urogynecologist who will help with that as well. There are other types of therapy where for people who are having too much urine in their bladder, where we'll actually go and put in a catheter to be able to release some of that fluid as well. And then more recently, in the past several years, botulinum toxin got FDA approved also to treat overactive bladder. And the idea is that just like when you think about the use of botulinum toxin where it weakens muscles overall, that's kind of why when people use it cosmetically, what it does is it weakens your muscles, and so it kind of gets rid of those wrinkles. People can use it similarly inside the bladder itself. It involves injections into the bladder, so this is generally done by a urologist, so a person who's a bladder specialist. And what it's been found to do is to really reduce some of those bladder symptoms. And so if you're having bladder symptoms with MS, make sure to bring it up to your neurologist. And then if your neurologist feels comfortable with treating it, that's fine. Your neurologist may want to get the advice and get the opinion of a urologist as well.
And can I just add 2 sentences to that? I think, again, talking about symptom management, it's still very important to make sure that we try to understand the cause of the symptoms, right? So certainly bladder symptoms can be caused by MS, but if you're a woman, if you've had any babies, right, I've had 2, right, you can have bladder symptoms from that too, right? And for gentlemen, there can be issues with the prostate. So we want to make sure that we rule out other causes before we say this is just the MS, and that we treat those other things appropriately. And that often involves a collaboration with a urologist.
Thank you.
Are we on this side now?
I have a question for Dr. Danielle. Specifically, I like the way you think and I like your approach. And the question is, I've been hearing, I'm a little bit of ignorant about the whole topic, but I've been listening to some conversation about epidemiology, and what it represents is about the clearing of the toxicity. And they put the Mother Earths in different environments, and they become different parts. For example, if you put a Mother Earth into protein, it may become an organ. And so I know that the cells have an intelligence, and they can reverse and reboot and come back to the original information. So I believe that the toxicity that goes on between the MS is the brain doesn't connect with the nerve system, right? Is that what happens? Are you following me?
It's for you.
For me. So I think the question had to do with what really happens in MS.
No. The question is if the body gets really put into the right environment, the cells, can they reboot and heal themselves and reverse? Because
Absolutely.
the cells are alive. So it's not about all these approaches. If you take the cells and put them in the proper environment, like they do cancer, like they do other things, the whole system, the intelligence of the body will reverse itself and will know how to go back and reboot.
A lot of what happens in MS actually is that the body does recover. Traditionally, people thought that the nerves, once they're damaged, they don't grow back. We now know that the body does heal itself in a lot of ways. The problem is the body can't heal itself when it's still being attacked all the time. And that's why we think about those disease-modifying therapies that we heard about earlier, because the idea is to stop your body from attacking itself. When the body can stop from attacking itself, then what can happen is the body can heal itself. And so in more recent years, actually, we've seen a lot more data and information on people actually having recovery or improvement of disabilities with MS, even with the current therapies that we have. And it's not necessarily that the medicines themselves are making you better. I agree with you. It's actually your body itself that's making you better, and you're having that recovery. One of the reasons we call it multiple sclerosis is not just because it's multiple problems at various times, but it's multiple problems that come and go. And now we know more about the going, that there actually can be improvement as well. Another aspect of that, about the idea of rebooting, has to do not just with the nerve cells and the covering of those nerves, but also with the immune system. So the body's defense forces, we're learning more and more about how the body's defense forces, if you bring it down, it can come back and almost reboot itself. And for some reason, you're a little bit less MSy than you were before. For example, people have heard a lot about stem cells. Well, one of the ways that we think stem cells work is that you're giving a person their own cells, and yet they're having less problems with the multiple sclerosis. So at first, it doesn't make that much sense. Why would giving somebody who already has MS more of their MS cells help them? But what it looks like is that by pushing down the immune system and then allowing it to come back, we have almost a rebooting that happens. So I think the rebooting happens with the nerve cells, but it also happens with the immune cells as well.
Next question.
This is for Dr. Daniel Kantor. You mentioned about people with MS have trouble with sleep apnea and sleeping. Is it possible? I've been to different seminars, and I'm very skeptical, but they have this new bed shipped from Italy, and there's a firm side and then a softer side or cooler side. The bed is different. I ended up purchasing it. I know, don't laugh, Dr. Steingo, because you know how skeptical I am. It happens to be very interesting. It's all cotton. It has like a base. It's not like a normal bed base. I had to switch it out already. It's like more like a trampoline looks like. But is it possible that you can sleep better and have less dust in your room if you get a mattress that's better for you, supposedly? And supposedly people have Parkinson's, and people say they sleep better. I was skeptical, but I bought the item.
It's an excellent question. So the idea of sleeping better can improve your functioning overall. Our bodies need to reboot ourselves. So that's why we go to sleep. It's one of the reasons why we sleep every night. And so if you're not sleeping well, because of many reasons, because of what's going on with your own body, whether you have tightness or whether you have pain or whether you have spasticity, but also if your cohabiter, so the person who's sleeping in bed with you, is snoring or bothering you or moving around, that can affect your sleep as well. And then your body's not recovering itself. That can be bad not just for your multiple sclerosis, that can be bad for your health overall as well. And the better that your health is overall, the better your multiple sclerosis is going to be.
So people with chronic diseases such as MS are very susceptible to witchcraft and scumbags and people out there like that. They'll sell you 1,000 different vitamins. If you go to the internet, and you could find 100 different vitamins for MS. You'll find beds for MS. You'll find all kinds of things for MS that really there's no scientific evidence. So always see what you can do for yourself first. And what they're talking about over here, I summarize myself just so I have a little bit of time just to talk myself for 1 minute. There's 3 things that you need to take care of yourselves. 3 stresses that your body faces every day before you spend money on a fancy bed or something else or some unknown vitamins. You have 3 stresses you face every day: physical, emotional, and nutritional. And look at those first and say, am I doing the best for all those stresses that I face before I go and spend money on a bed. And by the way, just my final editing on the cannabis CBD thing at the beginning, there are people out there that are shameless and selling this to people with MS inappropriately. And remember the way of the pain clinics, what's happened now at pain clinics, and some of the some of the marijuana CBD clinics are going to go the same way. Just in Broward County, a physician was arrested this past week for doing some inappropriate cannabinoid activities. So be careful where you go. Go to a place where that's got a reputation or where you're referred as well. Just be heed the people that are treating you if it's not standard medical practice coming from your MS practitioner. So you have the next question there?
Yes. Yes, I have a question about some of the challenges if you have multiple sclerosis and osteoporosis, and what some of the treatments for recommendation. Multiple sclerosis along with osteoporosis. What are some of the challenges that we have?
So the biggest challenge if you have multiple sclerosis and osteoporosis is the risk of injury, because if you have multiple sclerosis, you have a higher possibility of having a fall. And if you have osteoporosis, that means you have thin bones that the calcium is seeping out. So you should be making sure that you are doing everything not to fall, but then look at ways that you can help your bones be better. So, you know, eating right, a good diet that's full of calcium. You take calcium supplementations. You do some mild weight-bearing exercises. So, you know, I tell persons you don't have to go to a gym. You can, you know, maybe get your milk containers or your pee cans or something. You can just stand up and sit down, and that is using the muscles of your legs. So, and then it may be that you need to go to a provider. Most of the time it's your primary care, but it could be your GYN, and get a medication that will help stop that osteoporosis. And you need to then also have regular checks of your bone density to see how that's going. But the biggest thing is if you have osteoporosis and you have multiple sclerosis, you need to be very careful that you are not taking too much, quote, relapse management. So I have persons who, before disease-modifying therapies were out, are still coming back and talking to me about, well, I just need a little shot. Can you? I got the holidays are coming, and please just give me a little shot. And what they're talking about is they want a steroid to help give them, you know. So you don't want to have steroids any more than you absolutely need to, because steroids are highly associated with an advanced osteoporosis. So that's my recommendation for MS and osteoporosis.
Thank you.
Thank you very much. Everybody has been so informative. I wanted to address Dr. Kantor on CBD. I do take CBD not every day, but when needed for pain, and it really does subside the pain. Within 5-10 minutes, I can feel the pain lessen. It doesn't take it away, but it does lessen it quite a bit. And I also have a question for Patricia. She mentioned that to be a self-advocate, and I'm all for that. I live in the Florida Keys, and there isn't a lot of a big MS community down there. I have to travel an hour. And when I'm not feeling well, an hour could be 3 days, even in a vehicle. So anyways, I wanted to ask, you mentioned something about a book that where we can be an advocate, and it has all kinds of resources. I have to do my resources mostly online. You know, I have to travel 3 hours to see Dr. Steingo. So how can I help myself with that book that you mentioned?
Dr. Kantor.
And where can I find that book?
Well, Accorda had a booth out in the lobby, so if they're still there, but if not, you can go to Accorda's website, and you can get this book that has all of the MS foundations it listed in it. So that's the book that I referenced. The other book I referenced as far as cannabis is You Keeping a Log of Your Symptoms. But now all of us are required by the government to have EMRs, electronic medical records. And so I advocate for, because I have persons in Central Florida that come see me, and maybe they only drive a half an hour to see me, but I have persons from around Central Florida that come and see me, and they may drive just as far as you go to see Dr. Steingo. But in between visits, I can give them a mechanism through the EMR to communicate with me, and you don't have to come back and see me, but you have to communicate with me so that we can talk. And there may be times that that can happen, and there are other times that you may need to be seen, so you may need to make that truck. But the other thing is, if you live 3 hours away from Dr. Steingo or your neurology team, then you need a provider in your area that Dr. Steingo can communicate with and help. If you can't make it to his office, but something's happening to you, Dr. Steingo can communicate with your primary doctor or someone to say, hey, will you check out these things for me so that I can at least get the ball rolling to be sure that it's not a few things, exclude some things before you come up and see him. So again, I think it's a network. Taking care of persons with MS and persons who are in remote areas does take a network. And so then I'll leave Dr. Kantor the Merrill.
Oh, and I just want to add, it absolutely takes a village. So very commonly, you know, those of us who work at MS centers will have patients who have physicians. And I generally recommend, if you live over an hour or so away, that you have a local physician that we can communicate with, so that if there's an immediate need, you can get that met.
Absolutely. You had a question?
Thank you for sharing your experience with CBD. I agree with what we've said beforehand, that as it's out for longer, we'll have more experience in terms of understanding who it does help and who it doesn't help. Thank you.
Question here.
Okay, this question is for Dr. Williams. I know everyone has, their MS is different, but for me, when they were talking about all these things, Dr. Google and all that, but eating healthy, I eat a lot of stuff that my wife plants in the yard, organic, but I've noticed that we have soursop plants in our yard, and I drink the tea from the leaves of soursop, and I feel that helps me with my MS, and I wanted to know, what's your opinion on the soursop?
Say it one more time, the
soursop.
What is that?
It's green, big fruit. Mm-hmm. In Spanish is guanábana.
Okay.
But it's soursop, and they say you could eat the fruit or use the leaves as tea.
Okay, gotcha.
And I feel that for me, it's been going well, but I wanted to know, what's your opinion on that fruit, if you ever seen it or...
Right, so I don't have a lot of experience. So I'm in Atlanta. I don't think we have a lot of folks that use soursop. But I will say that I do have many patients who use different types of supplements, different types of juice, like for a while, noni juice was real big in Atlanta. But people use different types of supplements, eat different types of fruit or different types of juices or extracts. It really is an individual disease, as you said. So for some people, they feel really great when they use those things. If it's something that is not harmful, then I generally recommend, if you feel like it helps, go for it, right? But what I do think is that, as Dr. Steingo or Brian alluded to, sometimes people will be out there selling supplements, and on the other hand, I often will have folks come in and they have 20 supplements that they're taking 3 times a day in hopes that that will help or improve their MS. So I think that if there are 1 or 2 things that are working for you, go for it, but be careful that you can fall into a trap of taking 20 supplements. You're taking way more supplements than you are taking medicines for your MS, and that's also not necessarily the right way to go.
We have about 5.5 minutes left, so now if we're going to get through the next 20 questions, it's got to be speed answers.
20 questions? Okay.
I'm joking. One on the other side.
First, I want to thank you all and Stuart for putting on this seminar. It's been excellent, as they always are.
It's more than one person. It's an entire team.
I realize that, especially probably Stuart's wife. But my question is, through these seminars, I've always heard that it's the T and B cells that attack the myelin. Is there any research outside that box that says the T and B cells are doing exactly what they're supposed to do? Instead of the problem is that the myelin is saying, I'm bad, come and attack me. Any research saying that the myelin is saying I'm bad, and so the T and B cells do their job and go after it?
I've not seen research to that end, but I have in terms of thinking outside of the box. When we went to our most recent conference in Germany, there are medications or compounds that are being looked at that target different cells in the immune system. So typically when we think of MS, we think of T cells, we think of B cells, but there are treatments that are being researched that are looking at many different cells in the immune system, mast cells and other cells, to see how those interactions with the T and B cells or how affecting those cells may be a different way to approach or to target MS. But I don't have any research particularly about. Do you know of any?
Yeah, just briefly, every year we have a very large MS meeting in Europe, usually. It's called ECTRIMS, or European Committee on Treatment and Research in MS. And there's always a keynote speech, and in that keynote speech, we usually hear about different aspects of both the nervous system and the immune system that might actually be responsible for MS. So we're constantly looking at various things, like, is MS actually not a problem of the immune system primarily, but is it a problem of the nervous system primarily? Is it a problem of the covering of the nerves, of what we call the oligodendrocytes, the cells that make the myelin, the white matter covering? And so we're constantly looking at those different aspects to try to figure out what really is the chicken or the egg in multiple sclerosis. Great question.
What I was going to say is I imagine I'm not the only person in the room who's been told that they're an interesting case. Dr. Williams had said something about the boxes and things fitting in the boxes. I'm fortunate that Dr. Steingo is my MS doctor, but additionally I have something called mixed connective tissue disease. And many times they don't fit into any particular box, and it's very frustrating.
Right.
And I want you guys to talk about that, please.
I think one of the interesting things about MS, and I think we all could say, if you've seen one MS patient, you've seen one MS patient, right? And so, again, those are the best categories that we have, but oftentimes I tell people they don't read the textbook before they come in to see me, right? So sometimes we have to make the best categorizations we can, and we have to try to treat the autoimmune process to the best of our ability, but everybody just unfortunately does not fit in a particular box. I have several patients that I treat who have an autoimmune process going on. They may not fit all the criteria for MS, they may fit some of the criteria for something else. Autoimmune diseases often run in one person, so I have people who have MS, they have symptoms of lupus, they may have symptoms of rheumatoid arthritis. So basically it's a matter of the neurologist working with the rheumatologist to see if there's a treatment that we feel would cover both of the processes that we think are going on. So that's kind of the art of medicine, when people don't fit in those specific boxes.
Thank you. You have been very informative today. I'm back on the cannabis subject. You were discussing about a proper doctor. Now, where are they getting these doctors from that are prescribing the cannabis for us? Because I have already gone and gotten my card and been overprescribed. So I'm not using it. But I just want to know, where are these doctors? How do we find the proper doctor? Do our doctors prescribe it?
Well, in the state of Florida, so the first problem is in the state of Florida it's approved, but it's not approved by the federal government. So if you want cannabis in the state of Florida, this is a cash business, which now opens it to all these fraudulent practitioners out there. And so there's insurance won't cover it because it's not covered by the federal government. So you're going to have to find people that have signed up. For us as physicians here in the state of Florida, 3 of us over here in the state of Florida, I'm not sure what Georgia is. For us to sign up, we have to sign all kinds of regulations, involved with all kinds of rules and regulations, and it's an onerous, difficult thing that similar to pain management, physicians that prescribed pain medications in a way of goodwill were hounded. And so we don't often want to get involved with that. So I, in my office, will give you a list of some local people that I think are going to be honest. That said, there's already somebody I've scratched off the list for lack of honesty. This person was a neurologist. And the way they're practicing now is they've given up neurology and they're just doing CBD and are doing dishonest things. So that's my local experience for you, Robin, but let's hear other local experiences from the panel.
Yeah, the difficulty in Georgia is that it is currently legal for people to get the card, but not legal for doctors to prescribe. And so the difficulty for us as neurologists is that basically if we sign people up for the card, then we're responsible for monitoring people getting it off the street because it's not legal for you to get, but we're responsible for monitoring. So there's still a lot of work to be done where we are. There are some doctors for some of our patients who live a little further away, like South Carolina, other places, but I think that, forums, good forums like, for instance, MS Views and News, oftentimes people will hear from other patients some areas where people are prescribing, and then I think, again, talking to your neurologist about places they trust is important.
We're totally out of time, I was told, so we're only taking one last question, okay? And
we have minus 39 seconds.
Yeah, I see that.
Yeah, we have it.
I hold it.
Hi. My question is for Dr. Kantor, and you already touched on it a little bit about stem cell therapy. Are there any current FDA-approved stem cell therapies for MS, and are there clinical trials in this area going on? And at 70 years old, I usually don't qualify for any clinical trial, but even if it can help somebody else, I think stem cell is the future, and I'd like to hear your thoughts on that.
You look great, by the way. You said you're 70? Oh, wow, you look amazing.
The question was about stem cells. So first, what are stem cells? Stem cells, the idea is that when you have a mother and a father come together, one cell from each of them becomes a fully formed human being. And so what happens is our cells can become other types of cells, and we call those cells stem cells. Oftentimes, people with multiple sclerosis think that stem cell research and stem cells that are available are having to do with making new nervous system cells. In fact, most of stem cell research that's out there and most of stem cells that are used not in an FDA-approved way are actually having to do with the immune system, are making new parts of the immune system, not making new myelin, not making new nerve cells themselves. And so there's no currently FDA-approved way of doing stem cell treatment for multiple sclerosis. There is some research going on, and the way to find a research trial that's a bona fide research trial is to go to clinicaltrials.gov and to find out. The problem is, as Dr. Steingo has talked a lot, there's people who will prey on people with multiple sclerosis, and you'll see these advertisements, come spend $50,000 and come to Guatemala or go to California even and other places to be able to do that. And so I think the important thing is that we are continuing stem cell research. A lot of that research, unfortunately, has to do more with the immune system than with making new nerves. And I think that's frustrating because a lot of times the people who ask about stem cells are also people with progressive forms of MS. And most stem cell research that's going on actually doesn't have to do with progressive forms of multiple sclerosis. It actually has to do with people with very relapsing forms of multiple sclerosis.
And I think also to be careful when we use the term stem cells. So what we are talking about is more similar to bone marrow stem cell transplant, right? There are other forms that people call stem cell transplant that involve fat cells that are not the types of procedures that we're talking about that have shown promise with MS.
Well, I offered you to write questions if you want, so I'm going to do these two final questions that someone wrote. Just for 1 second, someone asked, if you have injection site reactions and dents in your skin, so-called lipoatrophy, does insurance company pay to help reconstruct this? No. No, they usually don't. And in the final question someone asked, really we covered this question with all of our answers, was anything in the pipeline to affect the prognosis of the disease? We spoke about medications, we spoke about stem cells, we spoke about things you do for yourself to power yourself to slow down the progression of the disease. So that was the end of this session. Thank you all very much for participating. Thank you to the panel for a great session. And thank you to Stuart. And good morning and good health. Thank you.